Good morning, students. We will wait for others to join. Okay, good morning. I think we can start. Maybe one more girl need to join, I guess. Okay. Can you hear me?
Yes, yes.
So last class we have seen till shoulder joint. So today we will see from elbow joint. Okay. So is there any doubt from last class? Did you practice shoulder joint? Okay, then nobody has practiced. See, like you cannot practice this PMJ at the last moment of the exam. Okay, so start practicing from now. Otherwise, it will be difficult for you to perform your OSCE. So in elbow joint, you will be having humero-ulnar articulation and humero-radial articulation, then radial and ulnar articulation. Okay, so that means like humero-ulnar articulation, humero-radial articulation, then proximal radio-ulnar articulation will be there. So together, this all three articulations will be your elbow joint or elbow will be helping you to perform the elbow movement. So in elbow movement we have three. One is your flexion, extension, then you have supination and pronation in the proximal radial ulnar joint. So first we will see about the humero-ulnar articulation. So the convex trochlea will be articulating with concave olecranon fossa. So the the humerus will be a convex surface and the olecranon will be a concave surface. So this two will be articulating. So the resting portion of the joint is the elbow is flexed to 70 degree and forearm is supinated to 10 degrees. So elbow will be flexed to 70 degrees and forearm will be supinated to 10 degrees. So this is the resting position. For this, for the all the movement, you have to keep the joint in this particular resting position. Then the treatment plane will be over the olecranon fossa, that is a concave surface, and you need to stabilize the proximal joint, that is the humerus, against the table. You can keep a small towel roll so that the elbow joint is not getting compressed over the bed. Then you can also ask the person to roll over the humerus to fix the hand. So in case if you are not able to stabilize the person, not able to stabilize the hand alone along with the bed, then you can ask the person to just lie down on the elbow, or you can just ask the person to lie down in the side and fix the humerus with his other hand. So in the side lying, he can just turn and hold the humerus and fix the humerus. Okay, so that in that way you can ask the person to stabilize. Then indication for this particular so here first distraction is you need to give distraction, then you have to progress the distraction so that you will be able to increase the flexion or extension of the elbow joint. So position of the patient, either supine lying with the elbow over the edge of the treatment table, or you can also make the person to be in side lying. So either way, however you are able to stabilize the person, you have to position the patient. So this is the position. So either in supine lying, you have to fix the person's hand over the table, or you can ask the person to be in side lying, and with his other hand he can stabilize the humerus. Okay, so this is the position of the patient. So position of the therapist is walk standing position. So you can either, if you are very tall, then you can also sit, so that you don't need to bend for a very long time. Okay, so in this resting position, in this position, the hand will be in resting. So you can see here, the elbow will be 70-degree flexed and mildly supinated. That is 10 degrees supinated. So from neutral, you have to supinate 10 degree. Is that clear? So that is your hand placement. So you have to hold the hand. So if you see here, you have to hold the radius. Sorry, you have to hold the ulnar part. So ulnar part will be at the medial side. You have to hold the ulnar part with your fingers like this. Then you have to do a scooping movement. Okay, scooping movement is like how you will be taking the uh, ice cream. So that is your scooping movement. Just distally you have to glide and do the scooping movement. Okay, so this is your distraction. Same thing like your distraction for the humero-ulnar ulnar will be like you have to position in the same manner, stabilize the person. Then you have to place your hand over the elbow, over the edge of the table. So here if you see, with the same position, okay, I'm sorry. So here you will be just giving the distal distraction alone. That means like you have to just pull down the elbow downwards. So that is your distraction. So next is like gliding. That is your distal glide. Here you have to do the scooping movement. Okay. So along with the distraction, you have to just pull upwards. Pull upwards means like it's like taking out the ice cream from the bowl. So that is the scooping movement. So that kind of movement you have to do. So this will give you a distal glide, and this distal glide will help you to increase the flexion. Okay, so next is humeroradial articulation. So we will complete the humerus, then we will see the video. So next is humeroradial articulation. So here if you see, the capitulum will be a convex and the radial head will be concave. Okay, so the humerus part will be concave and the radial part will be concave. Humerus part will be convex and the radial part will be concave. So the treatment plane again is over the radial head, that is the concave part. The resting position is elbow is extended and forearm is supinated to the end. That is complete supination and forearm is extended. So that is the resting position for the humeroradial articulation. So same like the previous one, you have to fix the humerus with one hand, like either lie on the side lying and ask them to fix the hand on the one hand, or you can also use a belt to stabilize the humerus. Okay, then you have to the patient, the therapist position is you can stand in between the hand and the elbow, or you can also sit over the edge of the table, and so that you can keep the hand over your thighs. Okay, so this is the therapist position. Either stand in between or you can sit over the couch and keep your hand over the thigh. Then you have to stabilize the humerus with one hand, or you can also wear a belt so that you will be you will be able to stabilize the humerus properly. Or you can also make the person to be in side lying. Then hold the radius. Okay, so hold the radius with one hand and give a downward pull. So can you see, with one hand you can just hold the radius alone, then give a downward pull. So this is your humeroradial distraction. So distraction will just help you to initiate the treatment. Okay, so after distraction, you can go for dorsal glide or a volar glide. So dorsal glide will help you to increase the elbow extension. Volar glide will help you to increase the elbow flexion. So position is same in supine lying, or you can also sit, make the person to be sit. It's better to be in supine lying. You can stabilize the humerus over the bed along with a trochanteric belt. Then you can use your one hand, hold the radius. So hold the radius upper articulating part, then push downwards. That is your dorsal glide. Pull upwards. That is your volar glide. Okay, so push downwards, that is your dorsal glide. Pull upwards, that is your volar glide. Is that clear? So this is your humeroradial, dorsal and volar glides to increase your flexion and extension of the elbow. So next is humeroradial compression. So this is done in case if the head of the radius has come out of the annular ligament. So we have an annular ligament that will be encirculating the head of humerus. So sometimes what will happen, especially in children, if you are lifting the children with the hand, if you're holding the children at the hand and lifting them, then the radial head will come out of the annular ligament. So that is called a subluxation. So to reduce the subluxation, we can do this humeroradial compression. So you have to keep a towel under the elbow here, or you can keep your hand to just give a cushion effect at the elbow. Okay, then you have to interlock the hand. So you have to interlock your hand along with the patient's hand. Interlocking means just oppositely you have to hold the palm. Okay, so interlock the hand. Then you have to give a compression along with the screwing movement. Like screwing up, you have to do it. Okay, so give a compression, along with that you have to give a screwing movement. So you can see the arrow down, that is compression. Along with that you have to do a screwing movement. So this will help the radius will go inside the annular ligament. Okay, so this will help you to reduce the subluxation. So this is your compression. So none of the other joint has compression. All the joints will be having only distraction. Only this joint will have a compression to reduce the subluxation. Is that clear? Okay, I think we will see this three video, then we will go into the next part.
This video describes how to mobilize the humeroradial joint. For this mobilization, we're going to need a wedge to stabilize.
Can you see the video?
No. No, miss.
The humerus, and we're going to put the video describes how to mobilize the humeroradial joint. For this mobilization, we're going to need a wedge to.
Can you see now?
Yes, miss.
Stabilize the humerus, and we're going to put the joint first in the resting position. Have the patient put their elbow fully extended and their forearm fully supinated. This is the resting position of the humeroradial joint. So we put the wedge underneath the humerus to stabilize the humerus. We're going to further stabilize the humerus with your hand, and then palpate the head of the radius where it articulates with the capitulum of the humerus. And first, I'm going to push the radius posteriorly, applying graded oscillations. This technique would help improve restricted extension because it is a concave radius on a convex capitulum. Then I can apply an anterior glide at the humeroradial joint, stabilizing the humerus in the same way and applying migrated oscillations. This anterior mobilization would help improve flexion at the humeroradial joint. This video describes how to mobilize the humeroradial joint. For this mobilization, we're going to need a wedge to stabilize the humerus, and we're going to put the joint first in the resting position, have the patient put their elbow fully extended and their forearm fully supinated. This is the resting position of the humeroradial joint. So we put the wedge underneath the humerus to stabilize the humerus. We're going to further stabilize the humerus with your hand, and then palpate the head of the radius where it articulates with the capitulum of the humerus. And first, I'm going to push the radius posteriorly, applying graded oscillations. This technique would help improve restricted extension because it is a concave radius on a convex capitulum. Then I can apply an anterior glide at the humeroradial joint, stabilizing the humerus in the same way and applying migrated oscillations. This anterior mobilization would help improve flexion at the humeroradial joint.
Degrees, is that not? Everybody sees that? So I want to go to about 70. Who's got a goniometer? Who wants to challenge the professor? Oh, I win money in this one. All right, so it's about 70 degrees. This is neutral. Neutral position. I want her at what? About 10 degrees. About 10 degrees, that's all. Just a slight movement as far as the forearm's concerned. My hands are going to come into the ventral side, taking up the slack, and letting her wrist kind of come right across my shoulder. And I take up the slack, get my elbows together, and I'm kind of scooping, okay? Not doing this. Can you see what I'm doing? Taking up the slack and scooping that elbow, the olecranon, away from the humerus. Rolling it out. Why is that? Because in this position, the olecranon is on a 45-degree angle. Okay? He's kind of like this. He's not straightening. Okay? So if I just do that, I'm not really getting him. So I let my shoulder kind of come in, and so her arm's resting onto my shoulder or onto my clavicle. So I got to get in there tight, don't I? And I get her in a position where it's comfortable for me. Reset, there's 90, about 70 degrees. There's neutral, about 10 degrees supination. My lateral, or I guess it would be the lateral side hand, grabs first. My other hand grabs over. In that position, get my elbows to my ribs. Don't want to be out here. Elbows to the ribs, because that's telling me the direction I'm going in. And I scoop and distract. Can you feel the distraction? Okay. It'd be ideal if I have a tech, and we can afford to have one, is to have them hold their shoulder down. Okay? So you don't always have that anymore. You don't have techs anymore.
I think I'm tendency to elevate.
Yeah, I tend to see that whole thing pull. So once again, I get in a position where I make sure that all this is not moving. So now's my starting point, isn't it? Do you see what I did with her shoulder? Now I'm just starting to do it. And there's my distraction. And even with that, look at how much her shoulder moves. But I can feel separation. She can feel it. And that feels good to
upward rotation, downward rotation. منطقة الفور ارم منطقة مشهورة جدا، بنبقى محتاجين نعمل الموبيلايزيشن تكنيك عشان ايا كان مثلا واحد مثلا عمل كاست وعايز وبعد فترة معينة في ليميتيشن في الرينج اوف موشن او ايا كان، فبنحتاج ان احنا نعمل الموبيلايزيشن. عندنا الالبو جوينت تو جوينت، هيومرو النر وهيومرو راديال جوينت. كل واحد بيبقى ليه تكنيك معين. التكنيك بتاعت الهيومرو النر، كل الفكره في الهيومرو النر هنا تكنيك واحد بس. بنعمل ايه؟ سيباريشن للجوينت سيرفيس. تراكشن يعني سيباريشن. ببعد السيرفيس بتاعت الالنا عن الديستال اند بتاعت الهيومرس بنفس الشكل ده كده، ببعدهم عن بعض. الريستنج بوزيشن بتاعه 70 درجه فليكشن، 10 درجات سوبرميشن، وباقي ايدي بتبقى بنفس الشكل ده كده عند البروكسيمال اند، وبس بركز اكتر ناحيه الايه؟ الالنا، وبعمل جوينت سيبريشن كده. ويفضل ان يبقى فيه ستراب يثبت الهيومرس. خلاص ده كده جوينت ايه؟ تراكشن. الريستنج بوزيشن بتاع الهيومرو النر جوينت 70 درجه فليكشن، 10 درجات سوباينيشن، وبريح الار عند الشولدر بتاعي. بحط ايدي هنا عند الالنا وبحرك الالنا ديستراكشن. السكوبنج تكنيك، بعمل ديستال جلايد للالنا عشان نحسن الرينج بتاع الفليكشن. من وضع الريستنج بوزيشن بعمل جريد 1 ديستراكشن وبشد الالنا في ديستال جلايد. الهيومرو راديال جوينت. الهيومرو راديال جوينت 3 تكنيكس بنستخدمهم فيها. التكنيك الاولاني عباره عن ايه؟ جوينت ديستراكشن. جوينت ديستراكشن ان انا بعمل سيبريشن للجوينت سيرفيس بنفس الشكل ده كده، ببعد السيرفيس عن الديستال اند بتاع الهيومرس. التكنيك الثاني عباره عن anterior glide وبوستيريور جلايد، anterior glide وبوستيريور جلايد. الانتيريور جلايد زي ما احنا شايفين الجوينت سيرفيس، البروكسيمال اند بتاعت الراديوس كونكيف والديستال اند بتاعت الهيومرس كونفكس. فانا لما اجي اعمل بوستيريور جلايد هيحسن الاكستنشن في السيم دايركشن، هعمل انتيريور جلايد هيحسن الفليكشن. الانتيريور جلايد بثبت البروكسيمال بارت اللي هي الديستال اند بتاعت الهيومرس. الريستنج بوزيشن الاول عباره عن ايه؟ البو اكستنشن وسوباينيشن. وايدي هنا عند البروكسيمال اند بتاعه الراديوس، وبحطها بنفس الشكل ده كده، وبحرك في بوستيريور جلايد. من نفس الوضعيه اشد لفوق، يبقى ده كده انتيريور جلايد. الهيومرو راديال جوينت الريستنج بوزيشن بتاعه حوالي البو اكستنشن، 4 ار سوباينيشن، وباجي بثبت البروكسيمال بارت الهيومرس، وباجي هنا عند الراديوس وبحركها في posterior جلايد. ممكن اسلوب تاني ان انا اشد الهيومرس لانتيريور جلايد لفوق. ديستراكشن تكنيك للهيومرو راديال جوينت، البيشنت بيبقى من الوضعيه حوالي سيمي فليكشن ومثبتين الهيومرس، وايدي هنا عند الديستال اند بتاعت الراديوس، وبحرك في ديستراكشن. في تكنيك تاني بنستخدمه في الهيومرو راديال جوينت، وهو الكومبريشن تكنيك. الكومبريشن تكنيك ده في حاله ايه؟ عندي انيولار ليجامنت وعندي الهيد بتاعت الراديوس، بعمل كومبريشن. ده في حاله الديسلوكيشن، لما يحصل ديسلوكيشن للهيد بتاعت الراديوس بره الانيولار ليجامنت، بعمل ايه؟ بحاول اكمبريس الجوينت جوه الانيولار ليجامنت بنفس الشكل اللي هنعمله دلوقتي. بنيجي 90 درجه فليكشن، باجي اعمل كومبريشن. اولا ارجع تاني، الكومبريشن تكنيك بنحط ايدي هنا اجينست الهاند بتاعت المريض، وبعمل كومبريشن ومعاه سوباينيشن بنفس الشكل ده كده، عشان اروتيت الهيد بتاعت الراديوس جوه الانيولار ليجامنت، واعمل ريدكشن للهيد جوه الانيولار ليجامنت. عندنا الحركه بتاعت
Okay, so any doubt in the three mobilization? Can we go to the next?
Yes, miss.
So next we have proximal radioulnar joint and distal radioulnar joint. So in these two joints, we will be having pronation and supination movement. So even though if it is not a complete synovial joint, this also has articulating surfaces. So if there is any addition in the articulating surfaces, the person will not be able to do a complete pronation and supination, which in turn will be affecting our elbow flexion and extension. So whenever the supination pronation movement is affected, it also will be affecting our elbow flexion and extension. So for that, so if you see here, the convex part of the radial head will be articulating with the concave part of the ulnar. So I'm talking about the proximal radioulnar joint. So in proximal radioulnar joint, the head of radius will be articulating with the radial notch of the ulnar. So the radial notch will be a concave part and the radial head will be a convex part. So here again the treatment plane will be along with the concave part, that is our radial notch, and the resting position will be the elbow should be in 70-degree flexion and forearm supinated 35-degree. So same like humeral ulnar distraction, you need to have the resting position at 70-degree flexion, and from neutral you have to supinate to 35 degrees. So from neutral you have to supinate to 35 degrees. So this is the resting position. So we need to stabilize the proximal ulnar because like the proximal joint for this particular joint movement is proximal part of this particular movement is your ulnar joint. So there is humero-ulnar joint will be the proximal joint. So we need to stabilize that. So after stabilizing, then you can see this is the position. Make the person to be in sitting position, or you can also position the patient in supine lying. So either in sitting or supine lying. In case of sitting, you need to stabilize the person's ulnar part using one hand. So if you see here, this is the radial side. You can see the thumb is upward. So this is the radial side, and down is the ulnar side. So with one hand, you have to stabilize the ulnar part. Okay, so with one hand, you have to stabilize the ulnar part. With the other hand, you have to hold the radius, head of the radius. With the other hand, you have to hold the head of the radius. Then give a push towards forward. That is your volar glide, and towards backward, that is your dorsal glide. So in the supinated part, this is your volar glide, and this is the dorsal glide. So this movement will help you to increase the supination and pronation. That is, the dorsal glide will help you to increase the pronation, and the volar glide will help you to increase the supination. Okay, so as the range of motion increases, you can progress to the further final degree of movement. Okay, so from 70 degree, you can slowly increase to maximum, that is 135 degree. And from supination, you can slowly increase to maximum of the particular movement. Okay, so till that you can go to progression. So next is distal radioulnar joint. So here the distal part, the ulnar notch of the radius. So the radius will be articulating with the ulnar. So here the radial part is called as ulnar notch, and the ulnar notch will be concave in shape, and the radial head will be a convex part. So again here the treatment plane will be along with the radius, that is the concave part, and the patient have to be in resting position with elbow supinated to 10 degrees. And we need to stabilize the distal ulna here, because that is the part we are going to uh, rest and do the movement. So you can see here, you can either make the person to be in supine lying or in sitting position. You have to keep the hand in 10 degrees of supination. So keep the hand in 10 degree of supination. Keep your hand down to stabilize the ulnar part. So keep your hand down and stabilize the ulnar part. Then hold the radius, that is the ulnar notch of the radius. Then do forward and backward. So that means you should not do forward and backward. From neutral, you have to do the forward glide, that is your volar glide, for increasing the pronation. From neutral, you have to do the dorsal glide to increase the supination. Okay, so dorsal glide will help you to increase the supination. Volar glide will help you to increase the pronation. So you should not do a to and fro like this. Okay, so from neutral you have to do either the forward, then from neutral you have to do either the backward. Is that clear? So this is your radioulnar joint to increase supination and pronation. So before going into the next joint, we will see the videos of it.
Proximal radial ulnar joint.
Very good. So with the proximal radial ulnar, the radius to the ulna, we have a convex outer ridge of the radial head that's going to be going in articulating with a concave ulna. So the convex concave rule comes into place. When the forearm goes into supination, we also have a ventral glide along with the rotation that takes place. So to enhance supination, I'm going to do a ventral glide of radius on ulna. And that takes place by getting the patient's humeral ulnar position at its open pack position of 70 degrees, and the radial ulnar position in its open pack position of about 35 degrees of supination. I put my thumb onto the joint line. My cranial hand is on the joint line. My thumb is at the joint line, and I'm going to stabilize humerus. I'm going to come down with my other thumb into the caudal dimension, and I'm going to take the thumb onto the radius, and I'm going to push radius into this position. I'm also going to have my thumb come down from that position onto more of the ulna and radius so I can feel that movement. From that position, I'm going to go ahead and do a ventral distraction, ventral glide, I should say. Ventral glide. Going in this direction, it's going to enhance supination. Conversely, with pronation, the radius translates in a posterior direction along with rotation. So I'm going to be in the same position, take up the slack, and I'm going to pull him in a posterior direction. The radial head, taking up the slack, and pull in a posterior direction. Okay? Ventral, posterior glides of the radial ulnar joint.
Proximal radial ulnar joint.
Very good. So with the proximal radial ulna, the radius to the ulna, we have a convex outer ridge of the radial head that's going to be going and articulating with a concave ulna. So the convex-concave rule comes into place. When the forearm goes into supination, we also have a ventral glide along with the rotation that takes place. So to enhance supination, I'm going to do a ventral glide of radius on ulna. And that takes place by getting the patient's humeral ulnar position at its open pack position of 70 degrees and the radial ulnar position in its open pack position of about 35 degrees of supination. I put my thumb onto the joint line. My cranial hand is on the joint line. My thumb is at the joint line, and I'm going to stabilize humerus. I'm going to come down with my other thumb into the caudal dimension, and I'm going to take the thumb onto the radius, and I'm going to push radius into this position. I'm also going to have my thumb come down from that position onto more of the ulna and radius so I can feel that movement. From that position, I'm going to go ahead and do a ventral distraction, ventral glide, I should say. Ventral glide. Going in this direction, it's going to enhance supination. Conversely, with pronation, the radius translates in a posterior direction along with rotation. So I'm going to be in the same position, take up the slack, and I'm going to pull him in a posterior direction. The radial head, taking up the slack, and pull in a posterior direction. Okay? Ventral, posterior glides of the radial ulnar joint.
Okay, now we will be performing a joint mobilization on the distal radial ulnar joint. First thing, we're going to have the patient rest their arm on the plinth, elbow slightly flexed, and forearm supinated to 10 degrees. We supinate the forearm to 10 degrees because this is the resting position of the distal radial ulnar joint. You're going to stabilize the ulna with one hand, and you're going to mobilize with your other hand. Mobilize the radius with the other hand. So let's say the patient presents with restricted pronation or has generalized hypomobility. Pull the radius in an anterior direction to perform your graded oscillations while stabilizing the ulna.
So if the patient presents with generalized hypomobility or has restricted supination, we can push the radius in a posterior direction. Perform graded oscillations as necessary. We push in these specific directions due to the concave on convex rule at the distal radial ulnar joint.
وباجي هنا عند الراديوس وبحركها في posterior glide. anterior glide. الهيومرس وباجي هنا عند distraction تكنيك للاند بتاعت الراديوس وبحرك في distraction. في تكنيك تاني بنستخدمه في الهيومر والراديال جوينت وهو الكومبريشن تكنيك. الكومبريشن تكنيك ده في حاله ايه؟ عندي انيولار ليجامنت وعندي الهيد بتاعت الراديوس. بعمل كومبريشن ده في حاله الديسلوكيشن، لما يحصل ديسلوكيشن للهيد بتاعت الراديوس بره الانيولار ليجامنت. بعمل ايه؟ بحاول اكمبريس الجوينت جوه الانيولار ليجامنت بنفس الشكل اللي هنعمله دلوقتي. بنيجي 90 درجة فليكشن، باجي أعمل كومبريشن. أولا أرجع تاني، الكومبريشن تكنيك بنحط إيدي هنا أجينست الهاند بتاعت المريض وبعمل كومبريشن ومعاه سوباينيشن بنفس الشكل ده كده عشان اروتيت الهيد بتاعت الراديوس جوه الانيولار ليجامنت واعمل ريدكشن للهيد جوه الانيولار ليجامنت. عندنا الحركه بتاعت البرونيشن والسوباينيشن بتحصل على تو جوينت، بروكسيمال راديو النر جوينت وديستال راديو النر جوينت. القاعده الثابته الديستال راديو النر جوينت الموفينج سيرفيس كونكيف على كونفكس، يبقى الجلايد في السيم دايركشن. لو انا عايز اعمل برونيشن يبقى بيحصل معاها انتيريور جلايد، سوباينيشن يبقى بوستيريور جلايد. الكلام ده فين؟ على مستوى الديستال راديو النر جوينت. البروكسيمال راديو النر جوينت العكس، الموفينج سيرفيس كونفكس على كونكيف، يبقى برونيشن معاه بوستيريور جلايد، السوباينيشن معاه انتيريور جلايد. الفور ارم الديستال راديو النر جوينت والبروكسيمال راديو النر جوينت. الديستال راديو النر جوينت بسيط، الريستنج بوزيشن بتاعه 10 درجات سوباينيشن من الميد بوزيشن، 10 درجات سوباينيشن من الميد بوزيشن، واحط ايدي عند الراديوس واثبت الالنا لان الراديوس اللي بتتحرك على الالنا، وبحركها في anterior glide posterior glide. نيجي على السيرفيس الجوينت البروكسيمال راديو النر جوينت. البروكسيمال راديو النر جوينت اهو السيرفيس اهو كونفكس واللي هنا كونكيف، فبالتالي الريستنج بوزيشن الاول بتاعه كام درجه؟ 70 درجه فليكشن و50 درجه سوباينيشن، وبحط ايدي هنا عند الراديوس وبحركها في anterior glide اللي بيحسن السوباينيشن، والبوستيريور جلايد بيحسن البرونيشن. الديستال راديو النر جوينت ليه اللوز باك بوزيشن بتاعه 10 درجات سوباينيشن من الميد بوزيشن. بنحط ايدينا بنثبت القلنه وايدي هنا عند مين؟ عند الراديوس، وبحركها في anterior glide و posterior glide. الفليكشن بتاع الراديو النر بروكسيمال راديو النر جوينت 70 درجه فليكشن و35 درجه سوباينيشن من الميد بوزيشن، وبنروح مريحين دراع المريض بنفس الشكل ده كده. بنثبت الراديوس من تحت والايد بتاعتي عند البروكسيمال راديو النر جوينت تحت الهيومرو راديال جوينت ب 2 ل 3 سم. بمسك الجوينت كده بحركها فيه anterior glide posterior glide. الريست جوينت عبارة عن الكرب.
Okay. So we'll have a break of 10 minutes. Then we will go to the next joint. Is that okay? The time is 9 o'clock now. We will meet again by 9:10. Next is our wrist joint. So here the wrist joint has radiocarpal articulation. So when we see the carpal bones is of 8 and it is arranged in 2 rows. So you will be having a proximal carpal bone and the distal carpal bone. There is proximal row of carpal bones and distal row of carpal bones. Here, so first if you see, the radius and the ulna will be articulating with the proximal carpal bones. Of course, for the good breast movement, that is flexion and extension of breast movement, you need to have good mobilization in the carpal bones also. So it is not only the proximal carpal bones, it is also like in between the carpal bones also you need to have good movement, so that you will be able to so that the wrist movement will be complete. So first we will see about the radiocarpal articulation. So the distal radius and ulnar part will be a concave surface. So both the distal part of the radius and the ulnar will be having a concave structure. So that is your uh, uh, treatment plane, and the carpal bones will be convex in structure. So the carpal bones completely, it will be like three bones will be forming: scaphoid, lunate, and the triquetrum. So those three bones will be having a convex part. So the resting position will be in line through the radius and the third metacarpal joint. That means the radius and the third metacarpal bone have to be in line. So if you keep that in line, if you there will be the hand will be in slightly ulnar deviated position. Is that clear? So that is the resting position. So we need to stabilize the distal radio-ulnar joint, and you have to move the proximal row. So first we will go for the distraction. So the distal radio-ulnar joint will be stabilized using one hand, and the other hand we have to hold the proximal row. So one hand we have to stabilize the distal radio-ulnar joint, and the other hand we have to hold it over the proximal row of the carpal. So hold at the proximal row of the carpal, give a pull distally. So this is your distraction. So distally means like a separating. Okay, so this is your, when you give separating, then you will have the distal pull. This is your distraction. So this distraction will give you a initial or what you can say, it will be giving you a this will give you the initiation of the treatment. Okay. Then we will be having a dorsal glide, we will have a olar glide, we will have a ulnar glide and a radial glide. So dorsal glide will help you to increase the flexion, olar glide will help you to increase the extension, ulnar glide will help you to increase the radial deviation, radial glide will help you to increase the ulnar deviation. Okay, first we will see the dorsal glide. So same in the resting position, you have to keep in such a way that the radius is in line with the third metacarpal. Then the hand will be slightly ulnar deviated. So in this position, we have to just give a pull towards the dorsal slide. So if you see here, this is the dorsal side. So if you give a pull upward, then that is your dorsal glide. If you give a push towards the supinated part or towards the palm, then it is a volar glide. Okay, so pull upward, that is your dorsal glide. Push downward, that is your volar glide. Then apart from that, you can keep the hand in ulnar deviation, or you can you have to keep the hand in mid prone position. So by keeping the hand in mid prone position, you can pull upwards towards the radial side. So that will be giving you the radial glide. Then push downwards towards the ulnar side. That will be giving you ulnar glide. Okay, so pushing towards the ulnar side will give you the ulnar glide. Pulling up towards the radial side will give you the radial glide. So when you do radial glide, you will be increasing the ulnar deviation. When you do the ulnar glide, you will be increasing the radial deviation. Okay, so we will see the video of all this movement. There is this four movement.
Okay, now we will be performing a joint mobilization on the distal radial ulnar joint. First thing, we're going to have the patient rest their arm on the plinth, elbow slightly flexed, and forearm supinated to 10 degrees. We supinate the forearm to 10 degrees because this is the resting position of the distal radial ulnar joint. You're going to stabilize the ulna with one hand, and you're going to mobilize with your other hand. Mobilize the radius with the other hand. So let's say the patient presents with restricted pronation or has generalized hypomobility. Pull the radius in an anterior direction to perform your graded oscillations while stabilizing the ulna. So if the patient presents with generalized hypomobility or has restricted supination, we can push the radius in a posterior direction. Perform your graded oscillations as necessary. We push in these specific directions due to the concave on convex rule at the distal radial ulnar joint. Okay, now we will be performing a joint mobilization on the distal radial ulnar joint. First thing, we're going to have the patient rest their arm on the plinth, elbow slightly flexed, and forearm supinated to 10 degrees. We supinate the forearm to 10 degrees because this is the resting position of the distal radial ulnar joint. You're going to stabilize the ulna with one hand, and you're going to mobilize with your other hand. Mobilize the radius with the other hand. So let's say the patient presents with restricted pronation or has generalized hypomobility. Pull the radius in an anterior direction to perform your graded oscillations while stabilizing the ulna. So if the patient presents with generalized hypomobility or has restricted supination, we can push the radius in a posterior direction. Perform your graded oscillations as necessary. We push in these specific directions due to the concave on convex rule at the distal radial ulnar joint.
glide posterior glide. الريست جوينت عباره عن الكاربال بون والديستال اند بتاعت الايه الراديوس والقطر. لما نيجي نعمل فليكشن الموفينج سيرفيس كونفكس على كونكيف، فبالتالي الانتيريور جلايد بيحسن الاكستنشن، والفليكشن بيبقى معاه بوستيريور جلايد. في وضع الريستنج بوزيشن كده بنثبت البروكسيمال بارت وبنيجي عند الكاربال بون ونحرك فيه بوستيريور جلايد. نقلب ونخلي العيان يعمل برونيشن، بنمسك الكاربال بون وبنثبت البروكسيمال بارت وبنحرك فيه anterior جلايد. بنثبت البروكسيمال بارت وبنمسك الكاربال بون، وطبعا بنبقى واضعين الجوينت في الريستنج بوزيشن سلايتلي فليكشن وسلايتلي النر ديفيشن، وبنمسك الكاربال بون وبنحركها في anterior جلايد. anterior الانتيريور جلايد بيحسن الاكستنشن. نعكس، ايوه، بنثبت البروكسيمال بارت، نحط ايدي هنا عند الكاربال بون برضو وبعمل بوستيريور جلايد. البوستيريور جلايد هيحسن الفليكشن. الفور ارم في الميد بوزيشن وبنثبت البروكسيمال بارت عند الفور ارم، وايدي هنا بتمسك الكاربال بون. بعمل ulnar جلايد او ميديال جلايد. ulnar جلايد او ميديال جلايد هيحسن الراديال ديفيشن. عايز اعمل راديال جلايد عشان يحسن الالنر ديفيشن، بنيجي نثبت الديستال اسبكت بتاعت الفور ار بايدي هنا عند الكاربال بون وبعمل راديال جلايد. الميتاكاربو فالانجيال جوينت ما بين البروكسيمال فالنكس والميتاكاربال زي ما احنا
I will now demonstrate a posterior to anterior and anterior to posterior mobilization at the radiocarpal joint. We'll start off by stabilizing the distal radius and applying in our web space the proximal row of carpals. As we stabilize the distal radius, we will apply a posterior to anterior force through the proximal row of carpals. This is a great technique to facilitate extension at the wrist. You can continue on by then stabilizing the proximal row of carpals and mobilizing the distal row of carpals. To do an anterior to posterior technique, we will ask the patient to supinate their arm. Again, we will stabilize the distal radius and apply in our web space the proximal row of carpals, and now we will go from an anterior to posterior mobilization. This will help to facilitate flexion at the wrist. Again, you can then stabilize the proximal row of carpals and mobilize the distal row of carpals.
Next, one more video on the same.
you are going to learn how to do arthrokinematic assessment and treatment for the ulnar capsule of the radiocarpal joint. Hi and welcome back to Physio Tutors. The aim of roll glide assessment is to gain information on reactivity of the joint and articular problems such as capsular limitations. For the push technique, have your patient in sitting position with the forearm in neutral position and supported on the bench. The patient's wrist is hanging freely. Then fixate the patient's forearm on the bench and grab the patient's proximal intercarpal row from radial. The intercarpals are the convex joint partner and the distal radio-ulnar joint is the concave joint partner. So when moving with the convex joint partner, we will have to roll and glide into opposite directions. Now, roll into radial and distal direction and at the same time perform the glide by pushing the proximal intercarpal row into ulnar and proximal direction. The proximal component is added as the distal radius reaches slightly more distal than the ulnar. An alternative is the pull technique. For this technique, the patient is either sitting or in supine position with the flexed elbow on the bench and the forearm in neutral position. The examiner is standing or sitting distal to the wrist to be assessed. Then fixate the patient's forearm with one hand and grab the patient's proximal intercarpal row from radially, like in an arm wrestling position. Now roll into radial and distal direction and at the same time perform the glide by pulling the proximal intercarpal row into ulnar and proximal direction. The proximal component is achieved by approximation. So you are pulling, but at the same time you are also pushing the intercarpals towards the radio-ulnar joint. For all techniques, assess for movement quality during roll and glide, possible pain provocation, and end feel. For end feel assessment, roll and glide to end range, then assess if further gliding is possible or not. In a hypomobile joint, the glide is reduced relative to the roll component, so no further gliding is possible. If you feel that the end feel or movement quality is abnormal, you can directly move further from assessment to intervention as the techniques are identical. When used as an intervention, make use of the Maitland grades of mobilization to dose your techniques according to your goals. Check the video in the top right corner to learn more about that. Okay, you've reached the end of this video. If you want to learn how to assess and mobilize the radial capsule.
Okay, the last video for the topic.
To learn how to do arthrokinematic assessment and treatment for the dorsal capsule of the radiocarpal joint. Hi and welcome back to Physio Tutors. The aim of roll glide assessment is to gain information on the reactivity of the joint and articular problems such as capsular limitations. For the pull technique, have your patient in sitting position with the shoulder and elbow in MLPP and the elbow in pronation. The patient places the elbow on the slightly lifted head part of the bench so that the wrist is hanging freely. Then fixate the patient's forearm on the bench and grab the patient's proximal intercarpal row from dorsal and embrace the intercarpals with your thumb and index finger on the palmar side. The intercarpals are the convex joint partner and the distal radio-ulnar joint is the concave joint partner. So when moving with the convex joint partner, we will have to roll and glide into opposite directions. Now roll into palmar and increasingly proximal direction and at the same time Perform the glide by pulling the proximal intercarpal row into dorsal and increasingly distal direction. The distal component is added as the distal radial ulnar joint reaches slightly more distal on the dorsal side compared to the palmar side. An alternative is the push technique. For this technique, the patient assumes the same starting position, only now the forearm is brought into supination. Then fixate the patient's forearm with one hand and grab the patient's proximal intercarpal row from palmar and embrace the proximal intercarpals with your thumb and index finger on the dorsal side. Now roll into palmar and increasingly proximal direction, and at the same time perform the glide by pushing the proximal intercarpal row into dorsal and increasingly distal direction. For all techniques, assess for movement quality during roll and glide, possible pain provocation, and end feel. For end feel assessment, roll and glide to end range, then assess if further gliding is possible or not. In a hypomobile joint, the glide is reduced relative to the roll component, so no further gliding is possible. If you feel that the end feel or movement quality is abnormal, you can directly move further from assessment to intervention, as the techniques are identical. When used as an intervention, make use of the Maitland grades of mobilization to dose your techniques according to your goals. Check the video in the top right corner to learn more about that. Okay, you've reached the end of this video. If you are curious about a more specific assessment,
Okay, so next is carpal bones. Do you want to see carpal bones today or next class? We have 25 minutes. We'll be able to complete it, but you can decide. Do you want me to go with the class or stop? Okay, then we will complete. So the last joint for the upper limb is the carpal bones. So we know that we have 8 carpal bones. So 8 carpal bones will be arranged in 2 rows, and there will be a space in between each bone. So whenever they have like uh, whenever there is some adhesion or there is a scar tissue or something inside the carpal bones or in between the carpal bones, it will be affecting the wrist joint as well as it will be affecting the metacarpals. Okay, so here the position of the person is sitting, then the therapist can be standing holding the patient's hand. So when you are holding the patient's hand like this, So the elbow will be hanging down, and this will give you a distraction force in the carpal bones. Is that clear? So you just imagine the patient will be sitting and the therapist will be standing opposite holding the hand. So when they are holding the hand, and when they are holding the hand, the weight of the elbow will be pulling the carpal bones, or the weight of the upper limb will be pulling the joint, and they will be having a distraction. So the all the bones will have some kind of a distraction movement. Is that clear? So that is the main aim of positioning the patient in sitting and holding the hand in standing. So the elbow has to be hanged unsupported. So that will be giving a slight distraction in between all the bones. Okay, then so first we will be doing the movement in the proximal, then we will be doing the movement in the distal. So whenever you want to increase, that is, if you want to increase extension, your wrist extension, then you need to stabilize the index finger under the bone, that is a concave part. Okay, stabilize the index finger under on the volar surface. So you can see in the picture. So stabilize the bone at the volar surface, then palpate the bone whichever you want to give movement with the thumb. Is that clear? So you have to stabilize the hand in your there is stabilize the proximal row of the carpal bones with your hand here, and you will be moving the distal row with the thumb. Is that clear? So you can see for each and every movement, you have to you have to use the thumb on each and every bone. That is, first you need to move scaphoid. So at that time you have to stabilize the radius. You need to move the scaphoid. Then again, like for all this, then whenever you want to move the lunate, you have to stabilize the radius. Okay, then you have to do the movement on the scaphoid, then separately on the lunate. Then you have to stabilize the trapezium and the trapezoid unit together. Then you have to move the scaphoid. Is that clear? So that what I'm coming to say is, so the proximal part you need to stabilize, and you keep over the distal carpal bone, and you have to move the bone individually. There is scaphoid separate, lunate separate, like that you have to do individual. Okay, so for each bone you have to do individual. Then you have to stabilize the lunate, then you have to move the capitulum. Is that clear? So you have to stabilize the proximal row, then move the distal using the thumb finger individually. Same wise for increasing flexion, you need to stabilize the convex surface on the volar surface, and you have to keep your thumb over the dorsal surface of the bone that is concave, and you are supposed to do the movement. So here what you do is, you will be stabilizing the scaphoid lunate and the and the capitulum. Then you will be moving the proximal row, that is your distal end of the radius again. Then you have to move the trapezoid and the trapezium bone together. Then lunate bone, then the triquetrum bone. Okay, so this is your proximal, you need to stabilize the carpal, and you are going to move the proximal row. Is that clear? Then, so if you want to stabilize the other, that is, in case the force is if you want to, you can also do it by, sorry. So you can see, I will just explain with this picture. So there are two, one is the proximal row here, then the distal row here. So the if you want to, whenever you want to increase the flexion, what you have to do is you need to stabilize the distal rows of the carpal, then you have to mobilize the proximal row. That is the proximal row and the distal part of the radius you have to mobilize. So in that case, what you have to do is you have to keep your hand at the olar surface and stabilize the distal rows, then you will be moving the proximal one by one. So whenever you want to increase extension, then what you have to do is you need to stabilize the proximal row by keeping your hand at the olar side. You need to stabilize the proximal row. Then you have to move the distal part. Okay, so this is to increase the movement in the extension. Okay, so each bone has to be mobilized separately, and whenever you're moving that particular bone, the proximal part or the distal part of the bone has to be stabilized. When you want to increase flexion, you need to stabilize the distal. When you want to increase the extension, you need to stabilize the proximal. Okay, so that is for carpal bones. Then next is carpometacarpal bone. There is distal carpal row and the metacarpal joint. So for this again, you need to stabilize you need to make the person to be sitting, then stabilize the hand using one hand. Okay, so you can stabilize the hand using one hand. So you have to hold the carpal bones, then you have to hold the hand, then you have to go for the distraction. So can you see here? So stabilize that particular proximal row, then give a distraction over to that particular moment. That means when you want to give first metacarpal distraction, then you need to stabilize the carpal bone, then you give distraction to the first metacarpal, then next metacarpal, then third metacarpal. Like that, each bone have to be given the distraction. So when you are giving that particular distraction, you stabilize the carpal bone just proximal to that. So this is carpometacarpal distraction. So same wise, you will also be able to give gliding and sliding. So gliding and sliding will help you to increase the finger movement. So if you want to increase finger range of motion, you will be able to do this carpometacarpal movement. Okay, so gliding and sliding of it will be. So you have to, the same way how you have given the distraction, you have to stabilize the proximal carpal, hold at the metacarpal head, then give sliding downwards or upwards. So downwards will be your olar glide and upward will be your dorsal glide. So this is carpometacarpal gliding. That will help you to increase the finger movements. So here, since the thumb was positioned separately, so in human being, the thumb will be positioned in a different plane. So this will help you to do the movement will help you to do a movement separately. You need to do a movement separately for the thumb because it is positioned in a different plane. It is not positioned along with your other fingers. It is positioned in a different plane. So for that carpometacarpal joint of the thumb, the resting position is in between flexion, extension, abduction and adduction. So if you see, the other fingers will have only flexion and extension. The other fingers will not have much of abduction and adduction. It will be having very less of abduction and adduction. But in the thumb, you will be having a complete flexion, extension, abduction and adduction. So the resting position will be, so in between the flexion and extension, abduction and adduction, that means it will be like a holding position. Okay, like when you keep your hand in in a cupping position, it will be like in a holding position you have to keep. Exactly. So that is your resting position. So stabilize the trapezium. So trapezium is the carpal bone ahead of the metacarpal of the thumb. So you need to stabilize the trapezium. Then you have to move the metacarpal for the distraction. Okay, so how to stabilize? You have to stabilize like this. Is that clear? So this thumb. So using your thumb, you are going to stabilize the trapezium. Then hold the thumb like this. So hold the thumb like this. Is that clear? Then you can apply the longitudinal force for distraction. Is that clear? So hold the trapezium using your one hand, then hold the thumb using the other hand in this position and give a longitudinal distraction. So this will give you a distraction force for the thumb metacarpal. Then you can go for the glides. So you can see you can do ulnar glide to increase flexion. So ulnar glide is this one. So when you are pushing the thumb towards the little finger, that is your ulnar glide. So you have to stabilize the trapezium here in this hand, hold the thumb, give a push towards the little finger. So that will be helping you to do the ulnar glide, and this ulnar glide will help you to increase the flexion of the thumb. Then in the other position, so you keep the hand in the supinated position, stabilize the trapezium using one hand, then you can see hold the thumb using the other hand, then give the downward push. So this is your dorsal glide. So this dorsal glide will help you to increase the abduction. Then in the same supinated position, you can stabilize the trapezium and give a push towards the radial one. So that is called the radial glide, that will help you to increase the extension. Then in a slightly supinated position, you have to stabilize the trapezium using one hand and hold the thumb and give a push towards the olar side. So that will help you to increase the adhesion. So all the other metacarpals will not have this much freedom of movement. So we are not going to do it separately. But metacarpals alone, we will be doing it separate. For the thumb alone, we will be doing it separately. So next is your metacarpal and phalangeal joint, that is your interphalangeal joint. So resting position is slightly flexed so that the joint is little bit loose. Then you have to stabilize the forearm over the table. Hold each bone and you give a distraction on the metacarpal or interphalangeal. So we have the metacarpal will be joining with the proximal interphalangeal, then you will have middle interphalangeal, then you have distal interphalangeal. So you need to stabilize the proximal bone and you have to give the distraction over the distal bone. Is that clear? So that is for your metacarpal. So each bone have to be stabilized and you have to you have to give the distraction over the interphalangeal. So same wise, you need to stabilize the metacarpal and you can give a volar push over with the intercarpal for the volar glide. Then give a dorsal push for the dorsal glide. So this will help you to increase the flexion and extension. Is that clear? So this is for flexion and extension. Now we will see the videos.
Peripheral joint mobilizations at the CMC joint early in the rehab protocol to increase range of motion at the CMC joint. Patient is going to be in a seated position, and the therapist will be standing, I'm sitting also across to the patient. To increase abduction at the CMC joint of the thumb, I will be performing a dorsal glide. So I'll have the patient put his hand like this, stabilize all the other metacarpals, and then grab on to the first metacarpal close to the CMC joint and apply a dorsal glide. I can use grade 1 and 2 for pain control, and then grade 3 and 4 to increase range of motion. Then to increase adduction at the CMC joint, I will apply a volar glide, which I'll ask the patient to put their hand like this, stabilize all the other metacarpals, and hold on to the first metacarpal here at the close to the CMC joint, and apply same grades, grade 1 and 2, and then 3 and 4. Then to increase flexion at the CMC joint, I will be applying an ulnar glide to the CMC joint. So I'll ask the patient to actually put their hand with thumb facing up. I will be stabilizing here at the other metacarpals again, and then provide an ulnar glide here. Then to increase extension at the CMC joint, I will be applying a radial glide to the CMC. So I'll be again doing this and applying a radial glide.
One more video.
Demonstrate roll glide assessment and mobilization of the first carpal-metacarpal joint into adduction and abduction. Hi and welcome to PhysioTutors. The aim of roll glide assessment is to gain information on reactivity of the joint as well as articular problems such as capsular limitations. The CMC1 joint is a saddle joint, so we will both roll and glide in the same as well as opposite directions depending on the movement that we will assess and mobilize. For adduction and abduction, the trapezium is concave and the first metacarpal is convex, which means that the roll and glide move into opposite directions. For this assessment, you can sit face to face of the patient. For the assessment of adduction and abduction, the patient's arm can lie on the bench. With your heterolateral hand, grasp the distal carpal row from dorsal in a way that your index finger can stabilize the patient's trapezium. Then, grab the first metacarpal bone as proximal as possible with your other hand between your thumb and index finger. This way, we can easily assess the roll and glide during adduction and abduction. For adduction, roll into dorsal and slide ulnar direction and add the glide into palmar and slide radial direction. For abduction, roll into palmar and slide radial direction and add the glide into dorsal and slide ulnar direction. For all techniques, assess for movement quality during roll and glide, possible pain provocation, and end feel. For end feel assessment, roll and glide to end range. Then assess if further glide is possible or not. In a hypomobile joint, the glide is reduced relative to the roll component, so no further gliding is possible. If you feel that the end feel or movement quality is abnormal, you can directly move further from assessment to intervention, as the techniques are identical.
In case you want to mobilize, you can use an alternative grip where you prop up the patient's arm on their elbow with the forearm in pronation. Then stabilize the distal carpal row with one hand from dorsal so that the index finger fixates the trapezium. Then grab the thumb with your entire hand and mobilize abduction by a roll into palmar and slight radial direction and add the glide into dorsal and slight ulnar direction. When used as an intervention, make use of the Maitland grades of mobilization to dose your techniques according to your goals. Check the video in the top.
I will now demonstrate a posterior to anterior and anterior to posterior mobilization at the radiocarpal joint. We'll start off by stabilizing the distal radius and up.
Okay, so I think that's all. See, you start practicing. Okay, so watch the video, start practicing positions and other thing. You exactly follow whatever given in the slides. Is that clear? So start practicing now onwards, so that like when you are doing, you will have a lot of doubts. You write down the doubts, then we will discuss in the class. Is that clear? If you don't practice, if you just see the slides, or if you just read the slides, you won't get any doubt. Is that clear? Okay, so thank you all. We will see you on Wednesday. Tomorrow is a public holiday. Okay, so we will see you on Wednesday. I think tomorrow we don't have class, right? Anyways, as per schedule, we will be having on Wednesday only, right? Okay. Okay, so see you on Wednesday. Bye.